Hello, everyone, and welcome to the NYU Langone Orthopedic webinar. And on behalf of the Department of Orthopedics at NYU Langone Health, again, we're very happy to have you join us, and we really do have a wonderful webinar planned. And for those of us involved in sports medicine and doing especially on-field coverage, I think you're going to find this webinar quite valuable for sideline skills and really for being up to date with everything regarding Sideline. So again, thank you so much for joining us. And I will also ask that, please, especially at the end of the talks, so we have 4 talks and they're approximately 15 minutes each, but all along the way, please ask questions. The instructions, guidelines were there. So we look forward to a very interactive Q&A at the end of the presentations. So once again, please ask any questions that you might have and with each speaker and topic. And let's get the webinar started. Our first talk is on management of the collapsed athlete, and Dr. Lauren Borowski will be our speaker. And Dr. Borowski is one of our sports medicine physicians here in the Department of Orthopedics. She's currently the medical director for Baruch College, Yeshiva University, and the Convent of Sacred Heart School Athletics. She has also a special interest in dance medicine, and she has been the head team physician for the United States men's ski jumping team since 2020. So certainly plenty of sideline ski slope coverage for Dr. Borowski. So with that, Dr. Borowski, please take it away.
Okay. All right. I'm going to get started because this is a very broad topic and kind of short time to do it in. So these are my goals for today. We're going to talk about some pertinent preparation steps for event coverage, discuss some initial assessment and management of the collapsed athlete, the different causes of the collapsed athlete, and some of the treatments for these various causes. The good news is that the majority of causes of the athlete collapsing are going to be benign and they are going to quickly resolve, which is great. But we really need to be expedient in determining the likely cause because this is going to be key to a good outcome. And we really want to remember that cardiac arrest is the leading non-traumatic cause of death in the athlete, and that has to be high on our differential at all times. So what do we do in order to prepare for our event in the first place? So we want to know and be familiar with our emergency action plan. So an emergency action plan, or EAP, is a comprehensive, detailed plan for most of the catastrophic events that may be happening, that may occur at the event site. The National Athletic Trainers Association has a position statement that helps walk someone through developing and implementing an EAP. This example on the right-hand side is one from event coverage, even internationally in Norway, that for men's downhill. And you can see the different various things that you should have on an emergency action plan. And those things would be that you want to include your personnel, who's involved, what are their roles, what are they going to be doing when the time comes for a catastrophe to have happened. What is your communication going to be? Is there cell phone service? Are you going to be able to use the cell phone, or do you have to rely on something like a walkie-talkie? What are the specific numbers you're going to call, and what order? Who are you going to call, in which order? And you want to know where your equipment is. You need to know where your location of your ambulance is. Where is the location of your AED? And are those things, the equipment that you're using, do they have batteries? Are they working? Are they functioning properly? You want to know where the transportation is going to happen. So if somebody needs to be transported from the event venue to the emergency room of the hospital, you want to know where is that ambulance going to pick up? What is the time to transport them from the venue to the emergency room? Or how long is it going to take for the emergency vehicle to get there? These are all details that you really want to know. You want to have the directions to and from the venue to those hospitals and a detailed map. So it's important to review this and be familiar with this prior to any event that you may be covering. Many athletics departments and sports medicine departments will actually publish their EAP, so you can actually just Google some of these things and you can have access to them. This is NYU's site just by Googling. They have several different event facilities, several different athletic facilities listed there, and they talk about their EAPs for those different facilities. So what are some of the supplies that you'll want to have with you should an event, should some sort of collapse happen at an event while you're covering? The biggest thing that you want to make sure you have is your AED. You want to make sure it's working properly, your automated external defibrillator. A blood pressure cuff with a stethoscope, so you can actually take the blood pressure cuff, is helpful. Having things like a glucometer to check your glucose, a rectal thermometer is going to be very important when it comes to exertional heat illness, and some way to detect sodium or other electrolytes like an iStat. Depending on what type of event you're covering, a way of cooling or heating a patient is going to be helpful, and then sources of simple carbohydrates. Obviously, this is not an exhaustive list, but important things that you should consider having with you when you're covering. So an initial assessment of the patient when they collapse, it is cardiac arrest until proven otherwise. If you get nothing else out of my lecture, cardiac arrest until proven otherwise, and you want to review your basic life support skills. We used to talk about the ABCs. Now it's more the CABs, where circulation is the most important part. As you can see through this diagram, the adult out of hospital cardiac arrest chain of survival, you're going to activate your emergency response. You're going to start high quality CPR, and that AED, you want to get there as soon as possible. Some protocols have started to talk about management of hemorrhage, actually, and unfortunately, this has come up in sports event coverage. It can happen from an ice hockey blade. It can happen from a ski in a high speed crash in a downhill race. And unfortunately, it happens in situations like the Boston Marathon. So knowing how to use a tourniquet can also be very helpful and is being taught in more protocols now too. So you want to make sure that when you see an athlete go down, you see an athlete collapse, you want to make sure that the scene is safe for you to go out there. You can't be of help if you become a victim yourself. So you want to make sure, let's say you're covering motocross or you're covering a downhill ski course. You want to make sure that course is clear before you go out there. You do not want to become a patient yourself. You want to check for responsiveness and activate EMS at the same time. Essentially, you get somebody else to do activate the EMS while you're checking for responsiveness. And if the pulse is felt and there's no breathing, you can start rescue breathing. But if there is no pulse or agonal breathing, no breathing, you want to start CPR as soon as possible with chest compressions. And you're going to obtain and use the AED as soon as possible. Just as a reminder, what good quality CPR is going to be. If you are a single person, if you're the only person that sees that athlete collapse, you want to start those compressions. Don't worry about giving breaths, just start compressions. Don't wait till somebody else gets there. Try to activate, try to call EMS and then get right back into doing compressions. If there's 2 people responding, you can do 30 compressions to 2 breaths for an adult and 15 compressions to 2 breaths for a child. You want to pause the compressions for rhythm analysis by the AED, and you really want to minimize the interruptions of chest compressions to less than 10 seconds if possible. If a shock is advisable from the AED, then you shock and then resume the compressions. If it's not advisable, then you just continue the compressions. You want to make sure you're switching out the person doing the compressions every 2 minutes or so in order to ensure that they're doing high quality CPR at a rate of 100 to 120 beats per minute, and you want to make sure you are allowing for full chest recoil. Good quality CPR is exhausting, so you want to make sure you're switching out frequently. Again, the AED is just so important to get on and to utilize as quickly as possible. The single greatest factor affecting survival is the time from the arrest happening to defibrillation. You want to try to get that defibrillation going, that defibrillator on and activated and a shock delivered within 3 to 4 minutes. For every minute afterwards, the survival rate goes down 7 to 10%. So early defibrillation and early CPR really does save lives. So let's say that you get to the patient and they're responsive. Okay, so you want to get some more history. You want to get vital signs. You want to know what their heart rate is, what's their respiratory rate, their blood pressure. You want to ask about allergies. Is there something that they could be having an anaphylactic reaction to? You want to ask about medications. Have they taken things for the first time, or were they supposed to take something and they didn't? Do they take supplements? Do they take stimulants that could be affecting their blood pressure? You want to know their past medical history. Do they have diabetes? Are they asthmatic? What was their when was their last meal? What was their hydration status? Have they been drinking just regular water at every mile of this marathon that you're covering? And then what are some of the events leading up to the presentation of the collapse? Is it traumatic or non-traumatic? like I said, there's a broad differential I'm going to cover on some of these topics, but I can't delve into a lot of them. So ask questions later in the chat if you can. So I'm going to cover some of the differential with cardiac, respiratory issues. I'm not really going to cover trauma today, some heat illness, exertional collapse, and then hyponatremia. A lot of different things can happen to cause a cardiac reason for a patient to collapse. There's cardiomyopathies. Hypertrophic cardiomyopathy is the most common reason in the United States that we have sudden cardiac arrest. In other countries, something like an arrhythmogenic right ventricular cardiomyopathy is more prevalent. You can have arrhythmia syndromes like Brugada, long QT, or Wolff-Parkinson-White. You can have an anomalous coronary or an aortic dissection, which you think of people who have more marfanoid syndromes. The person on the right-hand side of the screen here, this picture is depicting probably one of the most famous causes of cardiac arrest here recently that even if you don't watch sports, you probably have heard of in the last year, with Damar Hamlin, who we think had commotio cordis, which is actually a rare condition in which, usually it's a hockey puck, a lacrosse ball, baseball hits the chest at exactly the right time, the cardiac cycle, to knock it into VFib, to defibrillate the heart essentially. And it's really important to defibrillate it essentially back into rhythm. And we are very lucky that Damar is very lucky that he had a really great outcome. He had a really great medical staff taking care of him and got on top of this right away. Respiratory causes can be broken down into upper airway and lower airway. So are they having that anaphylactic reaction? Are they having an asthma attack? Do they have some sort of trauma that could have caused a pneumothorax? The treatment is really get oxygen into the lungs, right? We want to make sure the head position is in a good position in order to actually open up the airway. A bag valve mask is your friend. It can be extremely helpful to utilize that until you can get to a way of getting an advanced airway. Exertional heat illness is a spectrum of illnesses that range from cramping to heat stroke. The biggest difference between these things is temperature, and that's why the rectal thermometer is so important. Heat stroke really occurs at a core temperature of 40 degrees Celsius or 104 degrees Fahrenheit with mental status changes. And it's been shown that prolonged time at these super physiologic temperatures have been linked to cognitive and long-term negative outcomes. So when cooling is delayed, there is significant increase in end organ damage, morbidity, mortality, even after just 30 minutes. And so getting this person cooled is going to be key. As you can see on this diagram here, the symptoms can be, confusion, nausea, headache, dizziness. So you want to see what their temperature is. Some of the risk factors for exertional heat illness include exercising in high heat and humidity. We like to use the wet bulb globe temperature more so than the heat index because it takes into account things like heat, humidity, wind, but also the sun angle, the cloud cover. So the wet bulb globe temperature is a bit better than just using heat index. Lack of acclimatization, dehydration, whether they're very young or very old, also puts them at increased risk, obesity, and certain medications. You want to cool first and then transport second. So cooling is extremely important. There's different ways to do it. The water bath, ice water bath immersion is gold standard, essentially. There's different ways of doing that. You can have these portable pods that you blow up, or you can have an actual standing tub. The other way to do it is in that bottom left-hand picture. You see that ice taco. I found out, unfortunately, this summer that a grill cover actually works really well to make an ice taco tarp, especially one with the elastic on the edges to keep the water in. If you don't have ice and water, but you may just have water, you can and happen to have a fan, you can wet some towels, get the patient unclothed more, put the wet towels on, and blow the fan off. Blow the fan at them to remove some of the heat. So cool first, transport second. A couple more topics here. I'm trying to talk fast. The exertional hyponatremia is really what we're talking about often when we talk about the electrolyte disturbance. Levels are usually below 135 when we're talking about this. There's often mental status changes, but you can see the symptoms overlap quite a bit with the symptoms of exertional heat illness. We think that this happens, this exertional hyponatremia happens because people are ingesting a lot of water and then they don't really have this compensatory diuresis, essentially. At levels greater than 130, between 130 and 135, people are often asymptomatic or only just mildly symptomatic, and you can restrict their fluids and just watch them. But people who are less than 130 tend to have symptoms, and we want to avoid hypotonic and isotonic fluids, unlike the person who's got the exertional heat illness where we would give fluids, which is why it's so important to know the temperature. If someone is hyponatremic, you can give hypertonic saline solution at 3% hypertonic saline. Usually it's at small increments of just 100 mLs every 10 minutes or so for about three times. Or if they're with it enough, you can try to attempt some very concentrated broth, but usually it's the hypertonic saline that you'd want to give. And the last thing I'll talk about is this exertional collapse, or exercise-associated postural hypotension. So this is a diagnosis of exclusion. This is usually when someone crosses the finish line and then they collapse, or they collapse within a couple of minutes afterwards. And it is due to a transient loss of preload. So they're exercising, they stop exercising, the blood pools in the periphery, and then they decrease their preload. So that's what leads to collapse. You're going to lay the patient down, elevate their legs, and then assess their cognition and kind of go down that algorithm of, okay, do they have low blood sugar? Do they have low sodium? Is it exertional heat illness? Make sure none of that is what's going on as well. So in summary, collapse of the athlete is cardiac arrest until proven otherwise. So remember that, know where your AED is and know how to use it. Remember your CAB, your circulation, airway breathing, and your CPR basics. If the athlete is responsive, get a history. Check the temperature. If the temperature is near normal, or near normal, check a sodium and glucose. All right. Sorry I talked so fast. Tried to cover a lot in that 16 or 17 minutes.
Well, Lauren, that was super. A really great review of the collapse athlete, and certainly, yeah, great information. AED, 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 right? Yeah. Okay, and our next topic, we'll be talking about fractures and dislocations, common fractures and dislocations. And joining us to give that talk is Dr. Abigail Campbell. And Dr. Campbell, one of our sports orthopedic surgeons here in the Department of Orthopedics at NYU. And Dr. Campbell comes from a significant amount of sideline coverage, had been a doctor for the LA Dodgers, the LA Sparks, the Galaxy, and the Anaheim Ducks. And again, we're talking dislocations, reduction, and stabilization. Dr. Campbell, please take it away.
Thanks, Dennis. So I obviously was in practice in California for a while before coming back here a few months ago. And when starting to make this talk, I realized that talking about both fractures and dislocations was way too much. So we're going to focus on dislocations, which is honestly more common that we see on the sidelines, and fractures are a totally different universe. So we'll talk about the most common dislocations. Obviously, I'm not going to be able to get to every single joint in the body. We'll talk about the associated injuries that we worry about when you see these types of dislocations, what not to miss, when to go for it and jump out there and try to reduce it, and when you should image, call EMS, things like that, and then how you reduce, how you stabilize. So first, we'll talk about the evaluation. And most important thing I learned during my fellowship when we were covering a ton of sports is you really need to watch what's going on to see the injury. This photo my sister sent me when she saw me on ESPN. This was literally my first day of fellowship. And they were like, "You're going to go cover the Sparks game." And I was so nervous. You could see I was so scared to miss any play. It was terrifying because if you're the team doc and someone is down and everyone's looking to you, you're running out there and you have no idea what the mechanism was, you're going to look like an absolute clown if you weren't paying attention to the game, because often how the injury occurs is going to give you 80% of what you need to know. The other thing is history, right? So there's a lot of patients who have chronic shoulder dislocations. In hockey, they have shoulder club, is at least the hockey athletes I know. It's like people who get subluxations all the time and they just know how to put it back in. Or is this the first time? And is this a joint that they've had prior surgery on? These are all things you need to worry about. And then obviously when you're worried about a dislocation, you want to do the regular trauma workup that Lauren had alluded to, and then the standard neurovascular exam, and then the full extremity exam. And with dislocations, that's why we went into orthopedics. This is not rocket science. It's often not a mystery. It usually will tell you what it is just by looking at the extremity. So we'll start with glenohumeral, the most common type of dislocation that we see usually in sports. Over half of them at the high school, or over half of dislocations at the high school level are the shoulder joint, and overwhelmingly they're anterior inferior. The studies really show over and over again that pre-hospital reduction is safe and feasible in most cases. Reduction techniques, there's a few that we all learned during our training. So the one, at least in my program, we all used was like the traction counter traction, where you have to get them supine, you need sheets, you need 2 people. That actually only has about 61% success rates. The Stimson, which is a little bit less work if you want to leave them in the training room and you can't get it in otherwise, a little bit higher success, but also you need a weight, you need something to hang on their wrist. There's another technique that's been shown with about 95% success rate that was developed in like the mountains of France for skiing injuries, where they didn't have all this equipment and multiple people to help. And I've used this a few times myself, and it's worked every time. And it doesn't involve any pre-medication, supine, you can do it alone. Basically what you do is you have the patient sitting up, you hold their elbow and wrist, and you bring their arm up into forward flexion in line with the body, not the scapula. Then you basically have it adducted to the midline, so the sternum, and that's usually a little uncomfortable. And then once their arm is adducted and forward flexed, you slowly start internally rotating, and then you'll start to feel resistance at 20 to 30 degrees. And then you kind of have to force over this. That's when it's uncomfortable for them, but they shouldn't be like screaming in pain. And then it usually pops in around 20 to 30 degrees. Posterior dislocations, much more rare, 5% or less. Usually this is another one where you want to watch the injury, right? Because it comes from a direct posterior force on the humeral head. And this is easily missed because in anterior dislocations, you usually see the humeral head poking out in the front, but posterior, you don't always see. There's not always a gross deformity. The key in assessing this to know if it's posterior is that you can't passively externally rotate them at all. It doesn't go anywhere. And the reduction for this is kind of accentuating the mechanism. So you adduct, internally rotate, and then you kind of have to cup your hand under the axilla to push a laterally directed force to the humeral head to disengage it, and then you extend the shoulder. If it's not going in, don't retry. These have a high fracture rate, or they can have a huge reverse Hill-Sachs and be stuck on the posterior glenoid. If you're able to reduce, don't let them get put into a regular sling either with the hand on the belly, right? Because it's the posterior structures that are attenuated. So you want to put them in that gunslinger position. You could even just wrap up a towel or sheets and have them in between the waist to protect their hand from flopping down onto their belly. Inferior, it's probably not even worth talking about this because this is so rare. This is very obvious clinically. This is when you want to send to the ER and do a really thorough neurovascular exam because there's a very high rate of nerve and arterial injury in this, as well as fractures. And this one will need sedation. AC separation, technically a dislocation. Most of these you can really unsubscribe from. There's not anything acutely to do on the field or on the race course or whatever, but you do want to, obviously do a neurovascular exam and make sure that this really is just an AC separation and nothing else. You want to check out scapulothoracic joint, and then they shouldn't go back into play if they have this, obviously, but they can get imaging within 48 hours. It doesn't need any acute treatment during play. And then SC dislocation is kind of the one that we're all scared of the most. Orthopedically, it's quite rare. There's actually been less than 150 total cases of posterior dislocation reported in the literature. Anterior is much more common, and it's usually from a direct impact. So direct impact to the sternum, to the medial clavicle is where you're going to get the posterior dislocation. Direct impact to the lateral clavicle is when you get that seesaw, and then it pops anteriorly, which is much more clinically obvious. It's not always clear if it's a posterior dislocation because they will almost always have a hematoma there. So you'll be feeling around and you're like, I don't know, because there's always swelling there. So don't discard that diagnosis if you're, not sure, you're not totally convinced it's asymmetric. And then this one does have a lot of potential other problems that it could be, right? So pneumothorax, bronchospasm, or like a significant chest wall injury. And you want to look for all the scary stuff like dyspnea, hoarseness, stridor, any paresthesias, venous congestion, all of those things. Essentially, if an athlete has pain over the SC joint after a trauma to the chest, you should always be sending them to the ER. and you shouldn't be trying to yank on the clavicle or reduce this on the field. Elbow dislocation. This is one I've actually seen a lot in football athletes. I don't know about the rest of you guys. This one is the second most commonly dislocated joint. Deformity is very obvious, and it's usually posterolateral. Again, this is one that would help to watch the mechanism, right, to see what direction the forearm is being pushed in. Neurovascular exam is really important. I have heard of a few arterial injuries in these. So you always want to make sure you get a really great neurovascular exam. And then these is safe to start reducing on the field. This is a photo that shows the best reduction maneuver that I've had good success with. You basically hook the back of your elbow into their antecubital fossa and then grip their palm. And then you essentially use your own arm as traction to pull longitudinal traction, starting with our elbow extended. And then you slowly bring into extension. Usually supination will work for posterolateral dislocations, and it's a very obvious clunk. And then once it's reduced, you want to do a quick test of their stability. So is it more stable in pronation, supination? That helps you understand what ligament sided injury that we're talking about, ulnar or radial. And then they're almost always less stable in extension. So you want to have these people immobilized with the elbow in flexion, neutral wrist if you're not sure. If it's very obviously looser in pronation or supination, you want to stabilize in the most stable position in a splint. And then they still should always go to the ER for imaging because there's high fracture rate associated with this injury as well. Wrist dislocations, it's really hard to tell grossly if it's a perilunate, which is usually a much hairier injury, or a radiocarpal. There's both types of dislocations do have very high rates of median and ulnar nerve injury. So that's the first thing you want to be looking for. It's hard to know between the two without imaging. So on the bottom, you can see this is a perilunate dislocation, whereas on the right side, it's a simple radiocarpal, and the carpal bones are well aligned. You should call EMS directly if you do suspect a wrist dislocation. Make sure you're getting a good neurovascular exam, and you can just pull gentle traction on the wrist while you're waiting for EMS, but you don't need to start forcing it and doing funny things with the wrist like pronating, supinating if you don't know what it is yet. Finger dislocation, also very common. We see these all the time. In general, if someone has a finger dislocation and you see skin puckering, that means there's something stuck in there. It's usually the volar plate, but it can be a tendon. That should get imaged. Don't try to pop that in on the field because you could make it worse. The MCP joint is usually dorsally dislocated. This diagram I tried to show just kind of like what is going to get stuck in there to give a good image of it. I think that helps understand. So it usually comes out dorsally, like in this image. This one you really don't want to pull traction on directly because the volar plate can get stuck in the joint. So this is one that you want to relax the wrist first, or flex the wrist to relax all the flexor tendons. And then you basically want to push the base of the proximal phalanx in the opposite direction of the dislocation gently without significant traction. PIP, very common, also almost always dorsal. You want to worry about the collateral ligaments and the volar plate as well. You can see on the diagram there, the collateral ligaments often get sheared during a dorsal dislocation. This one, you want to hyperextend and then pull slight traction, and then you essentially will split in a slight opposite direction of where the dislocation was. DIP, it's usually dorsal or lateral, also very rarely would be volar. I've never seen one before. Again, you also worry about the volar plate in these injuries. These ones are usually pretty easy to reduce. You just pull longitudinal traction and then you splint in slight flexion. All of these you also want to send to the ER after reduction for imaging for any fractures, and they should be seeing a hand specialist within a week to assess for additional injuries. And then hip dislocation, again, very clinically obvious mechanism often will fit with this injury. If someone has hip pain and a leg length difference, you got to be calling EMS. Don't try to reduce it on the field. These always need sedation, far and away most common in football and teenage males, and it's a very high energy injury. About 10% of these also do have an acetabular fracture associated. And like I said, it's almost impossible to reduce these without sedating the patient. So this is when you got to kind of bump up and send to the ER. Ankle tibio-talar versus subtalar, sometimes a little hard to tell clinically which one it is based on the deformity, but there's a few key things that will help know, and that also affects how you're going to reduce it. As soon as you see that there's a significant ankle deformity, you should have someone calling EMS to get them brought to the hospital. Then you're going to do your obvious neurovascular exam. With an ankle dislocation, a true tibio-talar dislocation, usually the foot is plantar flexed because the talar dome is posterior to the tibia, and then you usually see the medial mal sticking out like that photo on the top. In a subtalar dislocation, it's going to be hypersupinated or hyperpronated. So usually it's a medial dislocation in which the foot, like on the bottom there, is hypersupinated and you see the talar head sticking out. Both of them do reduce with traction, but the ankle dislocations, the tibio-talar, tend to come in much easier than the subtalars. Subtalars will usually need sedation as well. So while you're waiting for EMS, you can basically cup the calcaneus, have the knee flex to relax the gastroc, have someone kind of water ski on the thigh to hold the leg up, and then you can just basically pull gentle traction on the calcaneus to see if you can get the ankle reduced. If it's not, it's probably a subtalar or there's a fracture fragment opposed. So these all also obviously need imaging, even if you can get it in. And that's all I have for dislocations. Thank you.
All right, Dr. Campbell, that was wonderful. I think when we're all on the sideline, I think we're hoping that we don't see that dislocation. But unfortunately, like you said, especially the shoulder dislocations can be quite common. And yeah,
so don't be scared. Try the French technique.
I like it. Viva la France. See, we. All good, all good. Okay, going on to our next talk and our next speaker, Dr. Guillaume Lomas. And Dr. Lomas, one of our sports orthopedic surgeons in the Department of Orthopedics, and also a team physician for the New Jersey Devils. And if there's a MMA bout of any importance or a boxing bout of any importance going on in New York City, there's a good bet that the Lomas is there in person covering. I often say to him, I don't know how he covers these sports. I don't know how he does it. So let's find out what his secret is. Dr. Guillaume Lomas.
Thank you, Dennis. And just awesome talks, Lauren and Abby. Just really, really good information. So a little origin story. If you don't recognize this skyline, this is Toronto, Ontario, home of the Toronto Maple Leafs. And that's my hometown where I grew up. And I was a big Leafs fan, like every young Torontonian might be. You know, I emulated my heroes, started playing hockey when I was 4. Problem with Toronto is that they absolutely sucked. They finished last every single year. Very frustrating as a child. A lot of tears. And so when I was 7, I switched allegiances to our hated rivals, the Montreal Canadiens. They had a really good team. So I won't lie, I was a bit of a bandwagon jumper. And sure enough, all the schoolyard fights that ensued were made worth it because the Habs won the Stanley Cup in 1993. So I remember watching actually on TV as they showed the parade and just could not be happier as a fan. And the reason I bring this up is that I've been a hockey fan my whole life, but being a team physician has nothing to do with being a fan. It has to do with being a team member, a game physician, an athlete physician, an integrator, an educator, and a communicator, as well as probably most importantly, an athlete advocate. So really as a team physician, and this is slightly different than the concept of sideline physician, but the idea is that you're going to be seeing these athletes for a prolonged period of time, throughout the season, certainly, and potentially over years. And so you have to have the same attributes that any doctor would have to make them successful. You have to be available, accessible, maintain sport-specific knowledge. And in a lot of these cases, you're going to have a role in medical and administrative management and will be interacting very intimately with the athletic training team. The hub and spokes model kind of is a good way of describing a well-oiled athlete care and team coverage machine. So at some point, someone's got to make the call, and that's usually a combination of the head team physician and head of athlete care. But you've got all of these other components that have to fit into athlete management. And so that includes everything from training staff to the coaches, the players, of course, their agents, other specialists on the team. You may have consultants that you send patients to or the athletes to, and then even the media wants to know what's going on. And so it's really important to have all of that centralized and one common messaging delivered in order to make everybody trust. I think that's the key, with all of this. And I think it applies to sideline coverage as well. But the most important thing you have is trust. And if you lose the trust of the locker room, you will not be successful at what you do. And the way you maintain trust is by being an athlete advocate. And you have to be realistic. You have to be transparent. And you have to be a good communicator and sometimes a diplomat, but you have to maintain trust. The second point I'll make is ego has absolutely no place either on the sidelines or taking care of a team. These are not your patients. These are athletes you're taking care of. And what you want is the best for them. You're not entitled to take care of them. You have, an opportunity and really, the honor of being able to help them apply their trade and do achieve elite status with what they do. But make sure that you park that at the door. And then remember to work hand in hand with other specialties. So most teams are going to have some form of internal medicine or primary care physician, a dental specialist, maybe a psychologist, and then emergency medicine specialist to manage any acute and potentially catastrophic injuries. One other point that has come up a lot recently is that most team coverage is managed by marketing agreements. And, interestingly here, for example, you've got the New York Rangers who have advertising from Northwell Health, but are also covered by Hospital for Special Surgery, and the Islanders covered by Northwell Health, but the main team physician is not at Northwell. So just examples of how you have to navigate the corporate landscape as well. So what about hockey specifically? So this is the fastest collision sport. You've got athletes that are pushing the limits, both aerobically and anaerobically, a lot of moving parts and a lot of sharp objects. Overall, you're going to see injury patterns that are pretty much evenly divided between head and neck, shoulder and arm, lower extremity, and groin and abdomen. And it's good to understand that you're going to see all kinds of injuries on a given day. It really can depend. One big thing that has come to the fore recently with more attention paid to concussions is that hockey do have a lot of potential for head contact. And this contact is occurring at a much faster rate than almost any other sport, probably shy of sport where you get on a horse or a car. So this is typically going to be managed by the primary care specialist or internist. And you're going to want a baseline scat on all of these athletes and then be able to reproduce that in cases of suspected concussion and obviously send to the emergency department or imaging if you're concerned. This is kind of like the stereotypical hockey player, no teeth, very common injury, up to 10%. It's funny, these days you see guys just chewing on mouth guards like chew toys. They don't like to have them, even though they're mandated to have, they don't like to actually wear them properly, even though it has been shown that there's no effect on VO2 max, at least in males. There may be some effect in females. And, the most common thing that we see is a fractured tooth. So it just kind of pops off. Again, a lot of these guys think this is a badge of honor. And so typically you're going to have your team dentist manage this, but, here's one of our guys. And I'm not sure if this is going to play. Yeah, there we go. So really high tech surgical management here with a pair of pliers. Looks like we're back in the Industrial Revolution, but he lost his tooth and got a nice crown to make up for it. All right, so lacerations have been a big news item recently. This is one that occurred last year. I don't know if you guys saw that, but Evander Kane had his arm stepped on. So he lacerated his radial artery.
Clutterbuck lugs it up the right side.
There we go. And that had to be managed acutely. Skates are extremely sharp. Modern skates are sharper than older skates. So it's something to be concerned about. Sometimes it's just superficial, even if it's big. Here's Barron from the Winnipeg Jets. He got 70 sutures, and that was done in the game, and he was able to come back. Always have materials ready to go, a suturing room, and you want to just know what you're doing. These guys are coming in. A lot of times they don't want to miss a shift. So you can use 3/0 nylon for limbs, a little smaller for face since it is more cosmetic, and anything inside the gums or mucosa, you're going to do an absorbable suture. So again, you want to do these in less than 5-7 minutes if you can, if they're not too big, and get them out as soon as possible. And these guys are pretty tough. They don't really need much local
power play.
So this is the famous Richard Zednik injury. So if you look at Zednik, he's in white.
Zednik! Oh my goodness!
Oh my God, it's really bad.
Richard Zednik is cut wide open. Oh my God!
So this is a really bad injury.
This
He
is
got,
ugly. Richard Zednik is cut wide open.
Skate and started bleeding profusely. In fact, they had to get the Zamboni out to clean the ice after this happened because they couldn't wash the blood from the ice. It was, probably in the liters category. And recently you may have heard about Adam Johnson, who died from a skate cut to his neck during the game. If you look at the picture on the right, that's the incident. The player in the red lifted his skates in the air and it cut Adam Johnson in the neck. And again, this is probably an injury. I don't know this particular case, that the details of it when it got transferred to the hospital. I'm actually not sure if it even made it to the hospital. I know he passed away, I think, in the ambulance. But this probably was an injury to either the jugular vein, maybe possibly the carotid. But the issue is that a lot of times these injuries occur in longitudinal fashion. So the neck is divided into 3 zones, and that was in zone 2. If you see this, you're going to want to have this quick clot control dressing and really stuff it into that area as best you can to stop the bleeding. This is a life-threatening injury. Again, these zones are divided 1, 2, and 3. And this is actually a paper that showed another skate injury. And you can see right here how it's longitudinal where the forceps are. And so this particular player had the injury repaired. And when they're repaired, they do fine. But obviously extremely dangerous and touch and go. So the thought has been, what about neck protectors, right? And so, seems obvious. The problem is that a quarter of the times that players have been cut, they were wearing neck protectors. And so these big lacerations occurred even despite these, and they also limit cervical rotation. So a lot of players don't like them. Now, Abby did a phenomenal job talking about musculoskeletal injuries, so I won't go into it too much, but this was my second day covering the Devils. A star player goes down, and again, seeing the mechanism, very helpful. This actually occurred at a bit of a blind spot in the rink where the physicians don't have a lot of good visualization, but we were able to see the replay. So you can see he's coming off the ice, not really moving that arm, so something's up. So, the thing is, in an emergency department, you have time, you can get imaging, but on the sideline, you have to make quick decisions. And I won't belabor, what Abby very nicely kind of summarized, but, your history is going to be very short. These athletes are not necessarily too excited at that time to give you a long history. You should have seen it. Physical exam, just seconds. Now, do you get x-rays before trying a reduction? Do you inject them? Do you sedate them? How much time are you going to take? So these questions all come up, right? Is it dislocated? Is it fractured potentially? Should it be reduced right then and there before or after x-rays? And what if you reduce it? Can the player return the same game? What happens if it's the Stanley Cup Finals versus first game of the season? Is it a close game? Is it going into overtime? What happens about, if the players got a contract negotiation pending? And then what about their past history? Like she mentioned, sometimes these athletes just are used to playing with a slightly unstable shoulder. They're happy to just pop it in and keep going. So you got to communicate this injury first to the player, to the coaching staff, let them know, are they going to have this guy available for them? Then to management, they've got to make personnel decisions. The agent will want to get involved, and then the media. So all of this takes a lot of attention and diplomacy, and you want to have a very consistent messaging, but also say the right thing and the correct thing to the right people. What about ringside reduction? So we know that there is a slight incidence of hidden fractures in these dislocations. But they tend to occur in older athletes. And so here's an example of one that was reduced. There's a tiny little fracture line right there. That's one that you got to be careful of. But I would say typically in these lower energy injury mechanisms, meaning they're not hit by a vehicle, fractures are a little bit more rare in these athletes. They tend to have very good bone density. So Abby gave some great examples of techniques to reduce the shoulder. Here's just a nice video of something in real time. So this is obviously not in a hockey rink, but on a wrestling mat. And this athlete dislocated. You want to try to reduce this within minutes. After that, the athlete starts to tense up. And here's one other technique that you can do, just very simple hyperexternal rotation. Again, just relaxing the athlete, maybe a little bit of traction, and then it tends to pop in pretty nicely. So with this athlete, the plan was, does he return to play the same game? We got it in. That was all good. He couldn't play. So that's a no. What about the same season? Surgery now or in the postseason, if not recurrence? I'm just going real quickly, over this, but the point is all this has to be percolating in the back of your head, right? So here's a study that most of these athletes were able to return in season, although there was a pretty high recurrence rate. Here's another study, similarly, pretty high recurrence rate. And this is out of Colombia, which showed a very high return to play with or without surgery. About half had gotten surgery, but a higher recurrence rate after non-operative treatment. So there's scores that you can run. And again, we don't have to get into the details right now. Just you have to have all of this in the back of your mind when you're deciding on a plan, and then communicate it to all the factors. So again, most important role, advocate. So you're going to talk to the player and see what they want to do and also guide them accordingly. So you do this together with the head of athlete care, usually the head trainer, develop options, communicate this with the player to management, the agents. The player in this case actually wanted a second opinion just because the agent knew somebody. We facilitated that. We don't own the player. We just provide the appropriate the services for them. And they were very happy that we got them a second opinion. They concurred with our plan, and then we monitored the player's progress and then provided the team media with a timeline estimate. And so he ended up coming back after about 8 weeks, 99 points the next year, has not dislocated since. The other point that I'll make is, you're taking care of players, but you're also taking care of their families and friends. And you want to maintain those same characteristics: availability, affability, and ability. A lot of times these are players and families from other states, countries. They may not be able to navigate the healthcare system, so you can provide that. And sometimes the injuries are to the men in black and white. And so you always have to provide care to those guys. They work just as hard as the players to do their job as well as possible, as well as visiting teams. So this, happened to me. And this is not HIPAA protected. It's known that Cal Clutter broke his nose in this game. And I happen to know the team doctor for the Islanders. And so called him, said, look, he's got a broken nose. I think he can play, he's breathing fine. That way everyone's on board. So a player was very confident going back in the game, knowing that his team doc and his training staff, everybody had kind of spoken about this. And so I will say, the old saw that I went to a fight and a hockey game broke out is probably the connection between this and combat sports. And I know we don't have a lot of time left. I work for the New York State Athletic Commission, and I'm on the executive board of the Association of Ringside Physicians, and I've been doing ringside medicine for 10 years. And really, just quickly, I'll kind of go over this. This is different. This is a little bit more sideline coverage in its true form, where you're just managing the athlete at the moment they're competing. You're not managing their entire career, their season. You don't necessarily have to deal with some of the other responsibilities. But basically, you stop a fight when the combatant is disabled or if there's a limb-threatening injury. You cannot provide treatment during a fight. You can examine the athlete, but you cannot provide treatment. So that's critical to know. So here's a fight, and we've been talking about shoulder dislocation. So this guy in the blue gloves, his shoulder seems to have gone out. And so here's the question: do you continue the fight? And the answer here is most likely no, because the shoulder's out. So if that doesn't pop back in, you can test him. You could say, is he able to do this? He probably has a shoulder dislocation and can't protect himself. The problem arises in cases like this. So if you look at the fighter in the white trunks, obviously something has happened to his shoulder. So it looks like a straightforward, got to stop this fight, right? So do you continue this fight? And most likely the answer would be no. Problem is, this fight was allowed to continue. And really, through the power of jab, this athlete somehow wins the fight. So you can never count some of these guys out. Remember, they're only fighting once in a while, and it is their livelihood. So very difficult. You got to assess all of these situations on a case-by-case basis. And some of this was already covered by Dr. Campbell, talking about reduction after the fight. Here's another example of a fighter who, if you look at round 2, you got to look at these guys closely. So if you look at Wok, he's the fighter in the white trunks, white and red. He's throwing punches, he's throwing jabs with his left hand, he's firing some hooks with his right hand. And now you go to round 7 and just see if you see anything different here. So it's a little bit like the last fight we saw, right? He's really just throwing jabs, and you got to pick this stuff up. It's sometimes it's very subliminal. And so in this case, do you continue the fight? Well, what's going on with him, right? So in this case, he's not throwing punches. You may want to have him squeeze your hand. Obviously he can't take his gloves off. You could have him do some push-ups, see if he can tolerate that. And then, of course, afterwards, you want to have him take his gloves off, just in case there is an open fracture. But, this athlete had a boxer's fracture, and that's why he wasn't punching. So, again, not necessarily going to stop the fight, but you have to be aware of this. And if the fighter can't defend himself, you got to stop the fight. All right. Well, just to finish up here, I'll just show a couple other things that we tend to see. High stakes here. That's a Kimura. That's going to be your spiral humerus fracture. This happens in MMA a lot. These kicks to the shin. We've seen a bunch of them over the years. That doesn't look right. And sometimes they truly are orthopedic emergencies where they need to be taken to the emergency department immediately. So here's an awkward landing that leads. If you look at his, I guess is that his right knee, left knee? That's his left knee. That's a full knee dislocation there. So thanks a lot, and sorry for going over.
Guillaume, that's a great talk. Thank you so much. I still don't know how you do it. I don't know the boxing MMA. I have plenty of questions for you. I always try to ask you. Maybe now that I have a whole audience, I could ask you some of those questions when we go to the Q&A. And for all of our participants, please, if you have any questions, please feel free to ask them. We will have a Q&A session at the end of our next talk. So please send your questions in, and we'll try to get to as many as we can. And we're going to switch gears right now, and something a little bit cleaner than Guillaume's talk, but part of his talk. We're going to be talking about concussion, and there have been some changes recently related to concussion. And let's see if we could advance my slides. Okay. So every 4 years, there's a panel of experts that get together in some very nice European city and really update our guidelines for concussion for athletes. And these are really mostly for sideline guidelines. But with the most recent update, which happened, the meeting was in October 2022, but the guidelines only came out maybe several months ago. They also switched up, and instead of just a scat, which is typically used on the sideline, there's also a new portion of it called a SCOT, which is actually very valuable. If you haven't seen any of this, it's quite good information. And it's about in that part, talking about the office evaluation for the athlete. Now, in the first 5 meetings, they came up with what they called the 11 R's of concussion for sports concussion. And our talk today will look at mostly the first 3, the recognize, reduce, and remove. The 2 new ones were retire and refine. I'll just mention a little bit about that towards the end of the talk. Okay, recognize. This was a definition that this consensus came out with, and it's not easy to define concussion. And certainly all of us have seen many different definitions related to concussion, but this is the most recent one that came out. And it's a blow, as we know, to the head, neck, or body, resulting in an impulsive force being transmitted to the brain that occurs in a sport or exercise-related activity. This initiates a neurotransmitter and metabolic cascade with possible axonal blood flow change and inflammation. And interestingly, as we know too, most of these are not structural injuries almost across the board. So imaging such as MRI or CT scan is rarely necessary, except in the cases of some of the red flags that we'll talk about. But typically only now in the research setting, abnormalities may be present and may be picked up on functional imaging, blood flow, or metabolic imaging studies. Very interesting to come out of the consensus was some prevention of concussion. And I think it's worthwhile reviewing these because for some of us, they're very different things than maybe we believed only just a few years ago. So one that's very important in terms of prevention is policy or rule changes. And there have been some nice changes that we've seen, especially in soccer and hockey, that have really made a difference. So again, this is right out of the consensus statement, but disallowing checking in youth ice hockey has decreased concussion rates by as much as 58%. So USA Hockey, for example, Canada Hockey now has rules in place where no checking for ages up until or starting checking at ages 12 or 13. And also limiting the number and duration of contact practices in football has reduced concussion by 64%. And certainly there's a big push now, certainly through 11, 12, 13-year-olds to be playing flag football instead of contact football. Here's a good one too, personal protective equipment. And mouth guards was always a question mark. And not so long ago, the thought was that mouth guards had no role in terms of preventing concussion. But some recent studies, especially this one that the consensus looked at, showed a 28% reduction when children, adolescents were using mouth guards in ice hockey. And this is a real nice one for us all who cover sports and sideline sports and see injuries, whether it's on the field or in the office setting. And that's a neuromuscular training program, has actually been shown to decrease the rate of concussion, specifically in a male population in rugby. So very similar to a ACL prevention program that we might be using, for example. So very, very interesting, but something that just needs more studies to look at more research in other team sports and in female athletes as well. And one big take-home message is secondary prevention, and that certainly is the mandatory removal from play for any athlete with an actual or suspected concussion. So now we're up to the third R, which is really our sideline evaluation, which is the most important part of our talk when we're on the sideline and we suspect that an athlete has potentially a concussion. So recognition of concussion, the first step to initiating the management of sports-related concussion. And it may be based on a player's symptoms or signs observed by other players, medical staff, or officials. And it's very different, for example, when I'm on the sideline, say, covering a high school football game in New York City. Years ago, there were so many coaches who didn't even think anything about concussion and getting an athlete right back out there and play. But nowadays, if I don't see a hit on the field, oftentimes I'll have a coach come up to me and say, hey, he's worried about a certain player. So really good information, even from teammates, from other medical staff on the field, and even from officials as well. So once we suspect a concussion, I think that's also a key takeaway here. If you suspect a concussion, that player comes out of the game immediately. And you don't need to make the diagnosis of concussion. They do not return to play that same day. The SCAT-6, more detailed definition of how to use it. So it's meant for athletes ages 13 and up. It's most effective in the first 72 hours after injury. But after 5 to 7 days, the clinical utility is in question, and that utility diminishes after 72 hours. And certainly for the office follow-ups, that's when you want to think about that office evaluation, the scoped evaluation. So what's new in the SCAT-6 compared to the SCAT-5? Well, one thing is the symptom scale is not new. So it's the same symptom scale with 22 symptoms, and we'll talk a little bit more about that. So that hasn't changed. And there's really been some good studies and evidence that show that it is one of the more sensitive things that we do in our concussion evaluation. Realize that it takes a minimum of 10 to 15 minutes to perform a proper concussion evaluation. And there's more importance placed now on the cervical spine assessment on the field, on the sideline, and in the office setting. So some of our psychometric tests that we do on the sideline in the office have changed related to more a ceiling effect. So if you remember with SCAT-5, we would give an athlete 5-word list and they would repeat it back, but now it's actually a 10-word list. Months backwards, we would just ask them to start with December and work their way back to January, but now it's a timed task where you give them 30 seconds to do it. If they do it longer than 30 seconds, then that does not count, and they lose a point for that. And revised coordination and balance to emphasize tandem gait testing. We'll talk a little bit more. And serial assessments after an athlete is removed from play. So here's the one where that athlete is down on the field potentially, and you suspect a concussion already, and you come running out onto the field. So the first thing to think about is any of the red flags. And our next slide, we'll talk about some of those red flags. But if any are present, then that really ends your concussion evaluation right there. You know that they're being removed from play. And in many instances with the red flags, it'll be immediate indication for transport to an emergency room. But other things to look for immediately when you're on the field, and many of you've heard about from during our previous talks, are certain observable signs, and we'll talk about that on our next slide as well. This is new on the SCAT-6. Never before was it a specific score given, but now if an athlete scores less than 15, that's immediate indication that they're out of play and certainly suspect at the very least a traumatic brain injury concussion. Like I said, there's more emphasis placed on the cervical spine and the neck. Coordination, ocular, motor screening is also a big part of what we do now on the field, in the sideline, and in the office setting. And we'll talk about the Maddox questions, because these are the types of questions that we should be asking our athletes when we do our initial evaluation with concussion. So here you could see, these are some of the observable signs that we look for when we come out onto the field. Is the player lying motionless on a playing surface? Did they fall unprotected onto the surface? Are they having any bounce or gait difficulties? Are they disoriented, confused? Do they have that far away stare that we all know when we see an athlete with concussion? Are there any facial injuries that may be accompanying their head trauma, impact seizures? And what about a high-risk mechanism of injury? Really, and that depends upon sports like we were talking about, like Dr. Lomas was talking about, covering such sports like MMA and boxing. So here are our red flags, and these are the ones where it's almost an immediate, often sending that athlete to the emergency room. Neck pain or tenderness, or one thing to think about is if that patient is not actively able to move their neck through a full range of motion. Seizures or convulsions, double vision, loss of consciousness, weakness or tingling and burning in more than one arm or in the legs, deteriorating conscious state, vomiting, severe or increasing headache, increasingly restless, agitated, or combative, again, the Glasgow Coma scale, less than 15, and a visible deformity of the skull. One thing to think about certainly is any progression of worsening of symptoms while that athlete is on the sideline. That's usually a red flag. So our cervical spine assessment, again, pretty obvious. Does the athlete report neck pain? Do they have tenderness to palpation? And the big one, again, is that will that athlete actively move their neck? If they don't, that really is an ominous sign of significant injury potentially to the cervical spine. Coordination and oculomotor screen, again, pretty self-explanatory if you pull up your SCAT-6 to do this, again, on the field, on the sideline. If you have the luxury, so you've done your on-field assessment, and now you bring that athlete to the sideline. So you can see here, this is a tent. And if you're, again, lucky enough to have a tent on the sideline, these are great to have the full attention of the athlete and not have much other outside stimuli. A really great place to do your sideline assessment. So this here is the 22 symptom checklist. So typically you would hand this to the athlete with a pen and have them circle their symptoms 0 to 6. And again, this has not changed from the previous SCAT-5. Here's the immediate memory word list. So again, very important. It's a 10-word list, not a 5-word list. So you would give them the 10 words, repeat it like 1 word per second, or say it 1 word per second, and then ask for the athlete to recite back as many words as they can and repeat that for 3 trials. The updated concentration testing about months, as we spoke about already. Now they're naming the months backwards from December to January, but the important change is timing it, and they need to do it in under 30 seconds. And then look at their coordination and balance. So a little bit of change here. We've always done the modified BEST test, and I won't go into that. Easy enough to get that information. So still using the modified BEST on the sideline or in the office setting. If that athlete fails the modified BEST, meaning they have a significant number of errors, then you do not need to go any further. But if their BEST is normal, the current recommendation now is to do a timed tandem gait. So the tandem gait is a really also nice test to go to, potentially even more sensitive than the BEST test, less subjectivity. And then optional would be to perform the modified BEST on a foam, on foam, or to do a dual tandem gait. And a dual tandem gait test would be while they're doing their tandem gait, you can ask them also to perhaps recite the months backwards or start with 99 and subtract 7s. So dual tasking, also a nice sensitive test that could be performed in the office setting. So there's been increased support too for serial SCAT-6 assessments. And I think for most of us, we've been doing that all along. So if the athlete has a concussion, we suspect it, most of the time they're on the sideline, potentially for the duration of the game or activity. And every so often, I know for myself, at least usually every 30 minutes, depending upon the severity of the head injury concussion, I would be doing a repeat evaluation. And scoring on this SCAT-6 is important for us all to remember, should not be used as a standalone method to diagnose concussion, measure recovery, or make decisions about an athlete's readiness to return to sport after concussion. So an athlete can score within normal limits on the SCAT-6 and still have a concussion. This is the updated time tandem gait that we talked about, the dual task gait. And just a little bit about the SCOT-6. So this is the office testing that I mentioned, and this is now a part of the recommendations in the consensus statement. So very similar, a lot of it, to the on-field evaluation. There's word recall and digit backwards. This is new now. Orthostatic blood pressure and heart rate at 2 positions, supine and seated or supine and standing, and really looking at for change in heart rate. Any change in heart rate, say greater than 30 beats per minute, would be abnormal. And the studies show that concussion does affect the autonomic nervous system and does affect heart rate, does affect blood pressure. So a nice test that should be done now in the office setting. More attention, again, to evaluation of the cervical spine, both on the field and in the office setting. A more detailed neurological examination is part of this evaluation compared to previous evaluations in the SCAT-5. And again, here in the office setting, a time tandem gait and a dual task gait, and better vision evaluation that we should all be doing, eye evaluation, and that's the VOMS test. The other R's I won't go too much into, but I will say, the big things are for the athlete who has concussion, some of the big changes now within 48 to 72 hours. The push is to already start that athlete on an aerobic exercise program of 20 minutes at a level that's not aggravating their symptoms. And it's really the same with school as well. So really not to cocoon these athletes in any way, but to get them started much earlier with a aerobic subthreshold type exercise program, and also to get them back to school or learning or work sooner than we would have done in the past. So key points to take away when it comes to the SCAT6 is that an athlete with a suspected concussion always is immediately removed from play. And we teach our coaches, for example, in the PSAL, when there's not maybe a physician or healthcare provider on the sideline, all they have to do, like for us, is suspect a concussion. And no matter what how the athlete does on the SCAT6, they should immediately be removed from play and not allowed to return to play. Concussion signs and symptoms can evolve over time. So that athlete who takes a pretty significant blow during an event, that athlete should be monitored closely on the sideline because oftentimes symptoms won't develop immediately. And an athlete can have a concussion even if the SCAT6 assessment is within normal limits. Always perform your basic principles of first aid. And as Dr. Borowski, Lauren mentioned, it's CABS now, CAB, for the unresponsive athlete. Assessment for a spinal cord injury is a critical part of what we do on the on-field evaluation. And always, 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 when you're doing on-field coverage, check for the presence of the AED. Where is the AED? And make sure that it's a working AED. Okay. Well, thank you. So that concludes our 4 talks, and we're going to have a Q&A session. So again, please send your questions, any questions that you may have related to any of the talks. And how about I'll get the conversation started while everybody's asking their questions. And I'm going to send a question to Dr. Lomas. And it's one that I've asked him, but, you mentioned a little bit, and I think, I just had a concussion talk. So it's kind of interesting when we talk about MMA and boxing, it's almost like the goal is really to cause a concussion. So I just wonder, what are the guidelines that you tell, physicians, healthcare providers on the sideline when to stop a fight? Meaning if you suspect a concussion, right? Any other sport, we just immediately take that athlete out, but very different boxing, MMA.
Right. Yeah. Great question, Dennis. And you and I have talked about this before. So this gets into, I would say that it's controversial because you're right. The goal for most sports is to try to mitigate the number of concussions, and it's hard to do that in a sport where that's really the primary objective. The I think ethical place where I think you can stand and be on somewhat solid ground is that, obviously these are consenting adults and they're participating in a sport that is high risk. So they understand these risks. I mean, it's very apparent to anybody who boxes or is in MMA that they're at risk for sustaining a concussion. And, I think the, comparison could be made to other high risk sports, anything from bungee jumping to wingsuit flying, motocross racing, car racing. So there are sports that, where the risks are even higher, right? It's like very likely that you might die. I think in wingsuit flying, if you look at everyone who's ever done that competitively, the death rate is in the double digits. But we still allow it because that's something that we believe people have freedom to choose. But to answer your question specifically, it's done a little differently. So we do not let athletes that we suspect to have sustained an actual concussion continue to fight. Now, you could argue that you can't always tell that in the moment, and I would say you're right. But you basically are looking for all the signs that you're looking at. I mean, just because you get hit in the head doesn't mean that you've sustained a concussion. We could have a whole other conversation about subconcussive blows. But basically what you're looking at is to see any sort of major changes in their performance, any psychomotor retardation, any balance, gait issues, somewhere where it seems like they're not, that there's been a pretty abrupt change in their performance, in their ability to do what they need to do. So I think that's probably the short answer, embedded in the longer moral question that you were asking.
Yeah, no, again, I think it's a very difficult position for a physician sometimes, for sure. So I give you all the credit for sticking with MMA and boxing. I have a question for Dr. Campbell. And Dr. Campbell, the question is, was covering a football game, and one of the athletes had a shoulder dislocation. So they took the athlete back for x-ray. They had x-ray there at the time. And while in the x-ray machine, did what looks like an axillary view and had a repeat dislocation. So I think the question, maybe, and I'll throw it out to all the speakers, if you have an athlete, what's been your experience with, especially with dislocation, shoulder dislocations, Dr. Campbell, Dr. Lomas, Dr. Borowski, if you have x-ray available, I guess you put them in the x-ray. Do you maybe avoid an axial view or certain positions that you won't do with that x-ray? Dr. Lomas? Dr. Campbell? Dr. Lomas?
I would suspect that's probably a recurrent dislocator if they're coming out so easily. But typically, if you have a patient, an athlete that you reduce immediately following the dislocation, which sounds like was appropriately done, don't just send them in, because the x-ray techs usually don't really know. They know the standard axillary views, the internal rotation view, and we all know what that risky position is going to be. It's abduction with some external rotation. And to get the axillary view, if you see the tech do it, they basically have the patient abduct their arm and then slide it out on a table over the plate. So usually if I'm imaging patients acutely, if there's x-ray available, I will physically go in and put on a lead gown, and I will hold their arm up and make sure it's internally rotated if it's an anterior dislocation, so you can get that axillary view to confirm. Also on a scapular Y view or an outlet view, you should be able to tell as well if the shoulder is dislocated. So I don't think you necessarily have to be getting axillary views acutely. You can tell on the Y, or you can always get a Velpo, but most techs don't know how to do that. But I'm sorry that happened. That's stressful.
No, that's great. Dr. Lomas, any? I know you've seen a bunch in ice hockey. Any different approach when it comes to shoulder dislocations?
No, I agree. The Velpo's nice. That's where their arm is still kind of next to their body, and you're trying to slide the cassette, sort of under them and shine the beam from top to bottom. But I agree with everything Dr. Campbell said. If you're there, just hold it. You know exactly how stable or unstable it is. So manage the athlete while they're getting their imaging.
For Dr. Borowski, hyponatremia really seemed to be in the news and a big deal previously, especially with marathoners. Don't hear as much about that anymore. Is there a reason? Do you think there's been enough information that's been spread regarding prevention of hyponatremia in marathoners?
It's a good question. I think that perhaps there has been. I mean, one of the reasons why that people get hyponatremia when they are performing a marathon or doing a marathon is because they're drinking so frequently. It's more of a risk for people who are the slower runners who are taking in water at every mile station or every water station. And so I think to some degree, maybe people have gotten a little bit smarter about their nutrition and their hydration status. But it is still, a big risk factor. So it is something when you're covering an endurance event, you want to keep in mind and have the ability to check.
I mean, nowadays they actually, for the slower runners, the advice is not to stop at every water station.
Correct. Exactly.
Course, right?
Exactly. And I think, with more of the goo packets and the different electrolyte and metabolic packets that people take throughout their running and their training, I think that's probably one of the reasons maybe why we're seeing it less. But yes, it is advised to not be stopping at every water station. You don't need to be ingesting that much water that frequently.
One for Dr. Lomas again. Dr. Lomas, what is the worst injury that you've seen on the sideline in MMA and boxing?
Worst injury that I've seen live. Well, I mean, I've seen some bad head injuries where, the athlete had to be sent to the ED. One of them had a subdural. They were fine, but they had to go to surgery. Fortunately, I haven't seen some of those big. I saw patellar dislocation, a bunch of shoulders. A Kimura, I've seen a fractured humerus. That the video that I showed was not a fight that I covered. That's just something I found on the internet. But the exact same thing happened, and it's an interesting video since we've been talking about dislocations a lot. It looks like the shoulder pops out, but actually in internal rotation, the shoulders, the ligaments are pretty resilient. So the first thing to go is the humerus. So they get these spiral fractures, and they can injure the radial nerve because it sort of like can sit right there. But so actually, I think it's probably your neck of the woods. It's been concussions have been the things that I've been most dramatic. Bad head injuries.
This for Dr. Campbell. Dr. Campbell, you said in your talk that hip dislocations you would send immediately to the emergency room without attempting a reduction. Any other dislocations that you would not attempt a reduction on the sideline?
Sternoclavicular is one that you're not really sure clinically when you see it, if it's that or what else is going on. That's one should go to the ER. And then everything else, like honestly, with most orthopedic stuff, if you acutely pull traction, most things will pop back in. Hips tend to not. You can kind of water ski on the foot and wait, but usually it's not going to go in just because there's so much muscle tone associated. And then with wrist, same thing. You're going to need the imaging. It's probably not going to reduce, but it's safe to pull. And then the fingers with skin puckering would be the only other one I wouldn't attempt without imaging.
I have a question for the panel, and I guess myself too. How to treat brachial plexopathy or stinger? If weakness is transient, can they return to play, risk of injury? Who would like to take that? Stinger. All right, I'll take it. So, and I think that was part of my talk and part of it in the red flags. If somebody has an upper extremity, they're getting symptoms in one upper extremity, that usually is a burner or stinger, depending upon the mechanism of injury. If somebody has symptoms in two arms or an arm and a leg, then that's more concerning. And not just a burner or a stinger. So what we typically do is the athlete comes off the field, they're holding their arm, they're weak, they're getting that numbness tingling, typically radiating down the arm. The diagnosis is usually pretty clear for a stinger injury. And then we just monitor them on the sideline. If their symptoms resolve and they gain their strength back, they have full painless range of motion of the cervical spine, their exam essentially returns back to normal. Then we let them return to play. Burners and stingers are interesting too. From my training many, many years ago, they've certainly become much less frequent. I used to see them much more on the sideline, burners and stingers in football, than I see them nowadays. I don't know, any comments from the other speakers, burners, stingers?
No, I agree, and I think it kind of highlights like an overall theme, which is common sense should prevail. So obviously there's some instances like we were talking about with traumatic brain injuries where you have to be more cautious than just like, well, the player wants to go back, they're kind of feeling okay. I mean, you want to do a very thorough evaluation there, but with burners and stingers, exactly, like if those symptoms are persistent, something is wrong. There might be a structural injury. That player doesn't go back. But in cases of transient symptoms. And, I would say we could have another conversation if it happens 2 times, 3 times in a game. Now maybe we're having another conversation with that player. But if their strength comes back, usually it's just kind of a little fluky thing. And I would not be worried about letting them come back. It's more the recurrence that I'm worried about.
I wonder if I was just going to say that in terms of like technique, I wonder if, the heads up kind of technique is to account for the decrease in the burners and the stingers. If they're actually appropriately tackling, that's why we're seeing less.
Maybe. Yeah. Really, really significantly less. And I'm glad you're here, Dr. Brodsky, because the next question is for you. What kind of cardiovascular exams should be done pre-season to rule out any cardiac conditions?
Oh, this is into a whole other topic with the pre-participation exam. I mean, obviously, the main reason that we try to do the pre-participation exam is to detect these cardiovascular things that could predispose somebody to sudden cardiac arrest. But it's the most important part of it is going to be your history. Right? Do they have chest pain with exertion? Have they ever passed out during or immediately after exercise? And do they have a family history of sudden cardiac arrest or death? And those are going to actually be are going to be more sensitive than your exam most of the time. And things that you're looking for on the exam are, murmurs or arrhythmias that you may pick up at the time of the exam. But it's really by far and away going to be the history on the cardiac portion that you're looking for to try to clue you in. And we could go into a whole other topic of EKGs and whether or not we should be doing EKGs on players. That's for another time, very also controversial. So I'm going to leave it at that. So do a really good history on your pre-participation exam with regards to cardiac history.
And it's very different, right? Certainly in our high school athletes and younger athletes, just like you were saying, EKG echocardiograms are currently not recommended really for all athletes, but it depends, right? Certainly we hear our D1 schools, they do EKGs and echoes, some of them, and it'd be interesting to hear Guillaume and Abby's experience with some of the professional teams that also do echoes and EKGs preseason. Guillaume, Abby?
I haven't seen echoes, but I've seen EKGs. And then I think in Europe, a few countries do preseason echoes, and it wasn't shown to be cost effective.
Yeah, same. Echoes are not done routinely in hockey.
Do you guys get an EKG on all the hockey players beforehand?
Yeah.
We get them in ski jumping and Nordic combined as well. So, probably definitely lower risk than some of the other higher risk sports, like our male black basketball players that are at higher risk of having sudden cardiac death and things that come up on the pre-participation exam. But if the availability to do the EKG is there and you have people who can read them, it's great to get it. But that's not the case for most athletes in most situations.
Another question for Guillaume, Dr. Lomas. Dr. Lomas, does it matter what state the bout, MMA or boxing, is occurring in terms of physician coverage and some of the decision making?
This is this is actually a topic that we tackle at the Association of Ringside Physicians often. So unlike other sports where there's a cohesive national body that's usually actually also in conversation with other international bodies. Hockey is just one example. Nordic and Nordic combined would be another one where you've got a national medical committee and then probably an international one as well. So with combat sports, every state has their own regulations. And so you saw, I'm part of the New York State Athletic Commission. Every state has their own athletic commission. We're trying to get all of that a little more cohesive, but it becomes a problem. And some athletes will fight in one state, like they'll fight in New York City. They'll get suspended for 3 months. And then, they might go to New Mexico. And for a long time, there's actually zero communication. So they just show up and fight over there if they wanted. So now at least there is communication between the commissions, but still sorely lacking a national body to oversee. And I think it just, it probably has its origins in how the sport started and the point of the commissions, which was to, take a sport that had a lot of gambling and this other illicit activity involved with it, and try to give some semblance of control and neutrality. So the commissions were supposed to be these independent bodies, and each state developed their own, and nobody ever kind of looked at it on a national level. So short answer, yes, but it's changing, and hopefully we'll get to a point where it doesn't matter where you're fighting, same regulations.
All right. Well, we're really a bunch of questions to go, but unfortunately, we're coming to a close. And one, to the speakers, great job. Thank you so much. Really, really, really super. And certainly for all our attendees, thank you so much for joining us. I know for us it was a pleasure and a lot of fun to do this. And we look forward to seeing you at future webinars. And on behalf of the Department of Orthopedics here at NYU Langone Health, again, thanks so much for joining us this evening. Have a wonderful night.